Okay. Hi, everybody, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined today by Dr. Aaron Boster, who's going to answer as many of your questions as he can in the next 60 minutes. Now I'm delighted to introduce him. Dr. Boster is a board-certified neurologist who lives in Columbus, Ohio. He specializes in multiple sclerosis and related central nervous system inflammatory disorders. Dr. Boster, we're so pleased to have you with us today. And I'm going to give a few directions to those that might not have joined us before as to how to put in their questions. And then we'll start. So,
Wonderful.
okay, so for anyone that is not familiar with it, we are going to accept your questions for Dr. Boster only in the Q&A area today. We're going to leave the chat area solely for the people that are joining us on Facebook. So if you can remember that, I might actually remind you later. It's going to be much easier for us to coordinate. This is going to allow Bhavya to use the chat, and all will be good. So if you want to ask a question and you're on the phone, you can actually hit *9 and I'll actually unmute you and you can ask your question. And if you want to just raise your hand with the raise hand button, you can do that also, and I'll unmute you for that. Otherwise, we're going to take all the questions from Q&A. So let's see what we have, if we have any questions yet. I know Bobby has said we have one. Okay. So someone's saying, I was on teraflutamide from September 23rd, rather September of 2023 to August 2024. And in February 2024, I started having nerve pain. In November, the pain stopped. Pain started back in March 2025. Is this something I'm going to have to deal with now?
So teraflutamide is one of the several oral disease-modifying therapies that we can take to treat multiple sclerosis. And there's a little bit of a mystery within this question. It is very rare, but possible, that teraflutamide can cause what's called a peripheral neuropathy. And that's a phenomenon where your fingertips and sometimes the tips of your toes can be numb and tingly. I'm not associated with teraflutamide causing pain. Now, the reason that there's a little bit of a mystery in the question is MS can cause pain. And so I think without more information, it's a little bit challenging to answer the question. In the setting of teraflutamide causing a peripheral neuropathy, that's something that can be clarified with a special test called an EMG nerve conduction study. And I'll wrap up the answer to the question stating that there is a host of ways of treating neuropathic pain. So no matter what the underlying cause, I would absolutely get ye to the neurologist so that we can use our lotions and potions and make that pain under good control.
Okay, thank you very much. Carla is asking, what is the most efficacious non-B cell depleter medicine? Right now, she's on Rituxan and getting infections even with IVIG.
So there's a host of MS medicines, and the real answer is most of them have not been compared one to another, but I'm more than happy to give you my personal opinion. It's my strong opinion that the most effective disease-modifying therapy approved by the American FDA is alemtuzumab or Limrada. Limrada is an induction medicine. It's an IV given for 5 days in a row. You wait a year and then 3 days in a row, and then you don't retreat unless you have new disease activity. And in my strong opinion, it's one of the only medicine that's more efficacious than the B-cell depleters.
Okay, thank you very much. Jennifer has quite the long question here. Let's see if we can get through this. I don't know how many parts there are, but hi, Dr. Boster. I have RRMS, lupus, MCTD, and PBC overlap. I'm currently on Kesimpta, but I'm wondering if it's too MS specific. My WBC is severely low, but it normalizes with steroids, which my rheumatologist believes points to immune suppression. My hematologist suspects marrow failure instead. Would rituximab offer better balance across all conditions? My MS neuro is firmly team Kesimpta. but I'd really appreciate your thoughts on what a unified cross-specialty plan might look like if I were your patient.
So, Jennifer, thank you for asking that question. It is a very complex question, and it's not your fault that you happen to have multiple autoimmune conditions. Now, the reality is I don't have enough information inside that question to give you a proper answer because I don't have your chart and your scans and all the things. But if I were to speak in generalities, I have many patients in my own clinic who suffer from not one, but two or three autoimmune conditions. And it's really very, very helpful in my experience to liaise or to work in conjunction with these other subspecialists. So arguably one of the very best things that you can do is ask the three nice specialists to have a chit chat so they can all put their heads together and get on the same team. That stated, traditionally, autoimmune conditions which require B-cell depletion use rituximab. Rituximab or Rituxan is probably the oldest of the disease-modifying therapy, or DMARDs, which is a B-cell depleter. It's been around the longest, and I think that rheumatologists certainly have the most experience with it. That stated, the differences between rituximab, Kesimpta, the one that you're on, Okervvis, and BMV are very, very small. To me, it's really like Pepsi, Coke, RC Cola, and Mr. Pibb. Like, they're all very, very similar. And in fact, the differences don't have very much to do with their ability to deplete B cells. It has to do with other aspects of them. And so I wouldn't think that it would make a big, huge difference. Oftentimes, when I'm working with someone who has both MS and another autoimmune condition, in conjunction with the rheumatologist, we'll do something like a B-cell depleter. So let's use Rituxan as an example, in addition to an oral immunosuppressant, something like a methotrexate. But again, my best advice is that they have a chit chat and put their heads together with your thoughts in the center so that we can try to come up with the best plan for you.
Okay, and I don't know if two down is actually coming from Jennifer and she went in as anonymous. Because very similar. Did you see that?
I do. Yeah, I'm not sure. It might be a separate question. We can most certainly tackle it.
Okay. My WBC has been slightly elevated, 11 to 12 for the past few years. I have been on Kesimpta for 3 years. My PCP says it's because I am immunocompromised because of the Kesimpta. Is she right? Is this common with Kesimpta, or do I need to push to have it investigated further?
So again, I can't diagnose or treat you on the interwebs, certainly with only 5 lines of text and without a lot of information. I can make some general comments, however. An elevation in the white blood cell count would not suggest immunosuppression to me. On the contrary, it would suggest that your immune response is kind of revved up. Am I familiar with a B-cell depleter like Kesimpta, Ocrevus, BMV, Rituxan increasing your white count? I'm not familiar with that. Although I will also share that, at least in my experience, seeing a white count that's slightly elevated like that wouldn't be too much of concern. Now, whether or not you need to explore it more, I can't answer that. I don't have enough information.
Thank you. I think this person is actually asking, is it hereditary, rather than it is hereditary with a question mark.
So I think the person's asking, is multiple sclerosis hereditary? So let's assume that's the question, and we can roll forward with an answer. So MS is not hereditary in the traditional sense. Oftentimes, in medicine, when we think of a hereditary disease, we think of something like sickle cell anemia or cystic fibrosis, where if you have it, 1 in 4 of your kids is gonna have it. And MS is most certainly not like that. There is a hereditary component of sorts. So I practice in the great state of Ohio, where actually the weather right now is beautiful. And I don't get to say that very often because a good portion of the year it's not. And in the Midwest where I practice, the average risk of MS, all comers, is 1 in 350. If you have MS, your first degree relatives, so mom, dad, brothers, sisters, kids, their risk is 1 in 40. And so it's obviously higher than the general population, but it's not a traditional hereditary condition. Great question.
Thank you. Aaron's asking if, I guess they've been seeing a lot of ads for the Octave test, and what is that? And do neurologists use it, and do you think it's helpful?
So I think that's a great question. Octave is a for-profit company who has created a blood test called the DA test, or disease activity test. And I'll tell a little story about it. They came to me at my center several years ago and asked me to start to participate in using this test in clinic. They shared that it wasn't fully validated yet, and they shared that patients have to pay for it. And I respectfully said no. I wasn't inclined to take on that, particularly given the lack of data supporting its use. They then, over the subsequent 3 years, did exactly that. They validated the test. And it's now had several very well-written scientific papers which have proven its utility. The DA test is a blood test, and I'll talk a little bit more about that in a second. And in the clinical trials, they compared the accuracy of the blood test against the risk of attacks and the risk of new spots on an MRI. And it's a very complex test that actually tests 18 different biomarkers, which is all summed up into this one score called the DA score. And the score can come back high, it's a numerical score, high, medium, or low. And if the DA is low, that correlates, generally speaking, with a low risk of new MRI lesions or attack. If the DA test comes back medium or high, then there's a concern that there may be inflammatory activity afoot. Now, the test, in my opinion, is valid. I've read the papers very carefully, and I believe in the data. I think it's a real test. It's not exactly prime time in that it's not approved by insurance just yet, which means that when my patients want access to it, they have to pay some money for it. And it can be like $200 or $300 for the test, which for many families is a no-go. The company has assured me that they're working very diligently to get it approved by insurance, but right now we have not had success in getting it covered by insurance. If the DA test was covered by insurance the way other labs are, I would probably get the test every 3 months because I find it to be that useful. I will say that it's not a holy grail, and it really, in my mind, could in the future become a surrogate where I wouldn't need to get MRIs as frequently because I would be looking at those test results. So that's the DA test, and I do find it to be useful.
Thank you. We have someone that would like to know your thoughts on how things look for the AHSCT compared to current DMTs.
So AHSCT stands for autologous hematopoietic stem cell transplantation, or a stem cell transplant. It's a certain type of stem cell transplant. And stem cell transplantation is a very exciting and evolving aspect within MS care or autoimmune care. When I first got into the field, it was a very scary thing to talk about because it had some very, very serious risks. And I'm delighted to share that over the many years, it's become increasingly more safe. In Great Britain, it is approved for very severe multiple sclerosis, and that's very, very exciting. Here in the United States, it's not FDA approved for MS, and outside of clinical trials, the average American doesn't have access to it. They certainly don't through their insurance product. There is ongoing research looking at hematopoietic stem cell transplantation, and I think we're at the point now where I can say with some comfort that it holds a place in MS treatment. I do think that it will become part of the MS treatment landscape. I would say that compared to most of the DMTs, it's much more dangerous, and it's much more complicated, and it's much more effective. And I would say that when considering stem cell transplantation, I sort of put it neck and neck or even a little above alemtuzumab or Limrada.
Hmm, thank you. Um, Someone is saying that they'd like to know, do you know if there's a timeline for colonoscopy with biopsy for suspected Okervvis-induced colitis flare-up?
So Okervvis is probably one of the most utilized MS disease modifying therapies for multiple sclerosis. It's one of the B-cell depleting agents, along with Kesimpta, BMV, and rituximab. And there is an extremely rare incidence of something called Okervvis-induced colitis, where you receive Okervvis for your MS, and it can cause a problem with your gut. It's not very common at all, and it's characterized by diarrhea, oftentimes bloody diarrhea. And it can be diagnosed with a colonoscopy where the GI guy puts a tube up your tushy and can take a biopsy of some of the tissue, and it has a particular lymphocytic appearance under the microscope to diagnose that. Now, the question is there a timeline for biopsy? And my honest answer is I'm not sure. I would suspect that you want to have it done when the colitis is active, but I can't give you more information on that. I have seen two patients who have developed Okervvis-induced colitis. Both of them were diagnosed with colonoscopy. And when I spoke to the GI guys, two different guys, neither of them found it very complicated to sort out. I'll share with you that one person took a little steroid and they're doing fine. And the other person, it wasn't that bad and they've just kept on keeping on. And so that's the best answer I can provide. Thank you for asking that question.
Mm. Laura said that she's had a hip replacement 7 years ago and she's still trying to fully recover. Is this common?
Is it common to take over 7 years to recover from a hip replacement? No, I would say that's not common. I will say that MS can complicate recovery, certainly. Now, I don't know if there were complications to the hip replacement or not, but I do feel like sometimes my patients can take a little bit longer to recover. Invariably, someone in Laura's position would want to leverage the utility of physical therapy to try to help guide that recovery. And I hope you have a faster recovery, Laura. Best of luck to you.
Thank you. Is motion sickness a red flag for MS?
No.
Good. I know a whole lot of people with vertigo,
Yeah, me
motion
too.
sickness too. Julio would like to know any update on alpha lipoic acid for MS?
Not that I'm aware of. Alpha lipoic acid, which is a supplement, has some data supporting its use for a special type of pain, so peripheral neuropathy from diabetes. Now, oftentimes we extrapolate, and if someone is having neuropathic pain for other reasons, we may try it. And I have some patients that have found it to be helpful. I have others that have tried it and not found it to be that helpful, but I'm not aware of any updates on data on it.
Thank you. And what are your thoughts on the Epstein-Barr virus and MS?
So I have several YouTube videos on this topic, and I think it's a really, really important topic. To summarize them, many of us now believe that one of the required steps for most people to develop MS is to have been exposed to the Epstein-Barr virus, mononucleosis, or the kissing flu. And it's largely driven by a very big study done in 2019. Now we've had this thought actually going back to the 60s, but in circa 2019 there was a really large study looking at 10 million people in the military here in the United States. And what they saw was 95% of them had EBV, mono, or had been exposed to it at some point in time, which is a very large number of people. And so that tells us that mono is very, very prevalent in the population. And obviously, not all those people had MS. But of those 10 million, 800 of these people in the military had multiple sclerosis. And all of them but one had been exposed to mono. And when you're dealing with numbers that big, that becomes quite statistically significant. And so the statistic is that having mono increases the risk for MS by over 37 times. And so that raises a lot of questions. There isn't currently a vaccine which has been proven to prevent EBV. In my fantasy and in my heart, I want a vaccine against EBV. And I envision that if we could vaccinate a population of children or infants, maybe we would have an entire generation of people that didn't develop multiple sclerosis. There's also some theories that if we were to develop a way to eradicate EBV activity, that might even be able to help people who currently have MS. And these are all works in progress. But the take home here is that as we try to best understand what causes MS, many of us now believe firmly that EBV is part of that story.
Hmm, great answer. Is there any PPMS drugs being developed that are not B-cell treatments?
Absolutely. At the Boster Center for MS, we're involved in a trial right now that I'm very proud of called the Perseus trial. And in the Perseus trial, we've enrolled people with primary progressive MS, and they're given one of two arms of therapy. There's a placebo arm, and there's a medicine called tolobrutinib. Now, some of you have heard of tolobrutinib because it was tested in secondary progressive MS in a trial called Hercules that we also participated in, and it was successful. It worked. It was a successful endeavor at slowing disability in secondary progressive MS to the tune of 29%, which is a really big deal. Now, tolobrutinib is currently being fast-tracked at the American FDA, and we are very hopeful, and we think that it will probably become the first FDA-approved therapy for non-relapsing secondary progressive MS. And if it works for secondary progressive MS, it will very likely, in my opinion, also work in PPMS. And so stay tuned because that trial will be wrapping up within the next year. And we'll be very, very excited about the potential for tolobrutinib for PPMS.
Wow, that is super exciting.
I agree.
Wow, 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 yeah. So Tina says that she takes baclofen for spasticity at night, 10 milligrams for spasticity. My mouth is beyond dry, she says. I can't quench my thirst no matter how much I drink. Is that a common side effect of baclofen?
Not in my experience. It is a common side effect with some other drugs. I use a lot of baclofen in my practice, and that's not one that I've heard very often. I'm not telling you that it's not causing your mouth to be dry, but I'm just sharing that in my use of baclofen, that's not normally one of the things that I hear often about.
Okay. And do you use low dose naltrexone as part of your treatment protocol?
So low-dose naltrexone, the medication, is a narcotic antagonist. So it was invented at higher doses to block narcotic effects. Low-dose naltrexone is oftentimes compounded in compounding pharmacies. And when I say low dose, we're talking about 4.5 milligrams or 3 milligrams. And I do not routinely use that as part of my treatment regimen. If a patient of mine expresses interest in low-dose naltrexone, I'm comfortable prescribing it in addition to whatever else we're doing. Which leads me to my three rules, if you will, for non-allopathic therapies or non-proven therapies. Rule number one is that it can't be dangerous. All right, so low-dose naltrexone is not dangerous. The only concern with low-dose naltrexone would be if you needed a narcotic, it might block some of its effect. Rule number two is that it can't be expensive. And fortunately for most families, the cost of compounded low-dose naltrexone is not too expensive. And rule number three is it can't be instead of something that I know works. So if a person said to me, hey, Dr. Boster, I want to stop my disease-modifying therapy for my MS and I want to take LDN instead, I would feel uncomfortable with that. But if they said, I want to continue my disease-modifying therapy and in addition take LDN, I'm more than happy to prescribe that.
Thank you. Robert is asking, can MS eventually cause fluctuation of the pancreas levels? Last 3 months, it's gone up too high, drops back down, and bumps back up. He said he's been on his 5th DMT since 2016, currently Tyabri for over a year now. I am seeing a GI and looped in my PCP and MS specialist.
My mentor used to say that sometimes nature is too generous, and you can have MS and you can have chronic pancreatitis, for example. I am not familiar with MS impacting the pancreas. I am familiar with other medicines and other conditions impacting the pancreas. And I think that you're going about this the right way by invoking not just the aid of your neurologist and your primary care, but also a GI guy or gal so that you can try to help get to the bottom of it.
Thank you. This person says that they walk unassisted most days for about 45 minutes and try to vary their terrain. However, when they encounter new places, like getting off of an airplane, and there may be a small gap between the plane and the ramp, their brain sort of freezes and they need to hold on to something. Can they do something to prepare for uncertain terrain when traveling?
Yes. I would strongly recommend working with a neurophysical therapist and describing exactly what you just described to them so that you can create scenarios where you are forced to grapple with sort of new situations like that. Now, you can't necessarily come up with every single possible scenario, but you most certainly could come up with varying degrees of gaps and varying degrees of step offs and the like so that you can help train the neuroplasticity of your brain to better circumvent that. And I think a neurophysical therapist would be aptly equipped to help you do that. Absolutely.
Thank you. And what is the difference between BMV and Okervvis?
Well, one starts with a B and one starts with, no, I'm just being silly. So both medicines are B cell depleters. All right, so they both work mechanistically to knock down the B cells. Both medicines are monoclonal antibodies. So they're engineered antibodies in a laboratory, and they're both IV infusions, and they're both given every 6 months. So they have a lot of similarities. The differences lie in the way that they were constructed. Okervvis is a monoclonal antibody where in a laboratory they humanized it. So they took out as much of the mouse protein as possible and they packed in as much human protein as possible so that it's typically better received in the human body. There's less infusion reactions when you take it. Briumvi is a chimeric molecule, and so that's a doctor way of saying it's mostly made of mouse protein. All right, so it's been less humanized. And what Briumvi did is they glycosylated it. So they did some fancy things to the attachment point, and it makes it stick around longer. And the theory is that it allows them to use a lower dose that lasts longer. So this is again sort of like Pepsi and RC Cola. They're more similar in many ways than dissimilar, and there's some tweaks to it. But hopefully that kind of helps you understand a few of the subtle differences between the two therapies.
Thank you. Is there any point in Copaxone these days, 2 years since diagnosis, and this person's been on Copaxone since then, waiting to find if eligible for a B cell depleter, feeling a little conflicted that Copaxone efficacy is really quite low?
That's a very good and appropriate question. I was trained by a gentleman who used a lot of Copaxone. In fact, my mentor developed the 3 times a week Copaxone and ran that clinical trial. And coming up through the ranks, we used a whole bunch of Copaxone. Copaxone is a very low efficacy medicine, as you suggest. And in 2025, I can list 26 medicines that are superior to Copaxone's efficacy. As a result, I don't find a home for it very often in my clinic. I do have a couple what I call legacy patients. I saw one of them yesterday, a fantastic gal who has been on Copaxone for a very, very long time, and she is a super responder to Copaxone, and we wouldn't want to take her off. But I don't have a lot of cause to use Copaxone in the modern era. The one thing that I'll say in Copaxone's favor, even in 2025, is that it doesn't cross a cell membrane, it doesn't trigger a receptor, and it plays very nicely in the sandbox with almost any other medicine or any other medical condition. And so when there's a problem, say, with severe immunosuppression, you could use Copaxone. MS and HIV, you could use Copaxone. MS and cancer, you could use Copaxone, and so on and so forth. That stated, I now have other drugs that I can also do that with, which I tend to find to be more efficacious. So as a result, Copaxone is not part of my personal formulary when I'm treating patients in the modern era.
Hmm. Thank you. Gus says that he came off of Plegridy 3 years ago due to high liver enzymes, and the side effects really sucked. He switched to MavenClad and completed both years. He had no side effects. Is this normal, or is this a sign that MavenClad didn't work?
I would submit to you that it is normal. I've given hundreds of people MavenClad, and the vast majority have tolerated it beautifully, which is awesome. And I'm really glad that you didn't notice very much. and it has no bearing on whether it worked or not.
Thank you. And Denise says, is it common for MS patients to have a high platelet count? She's been to a hematologist who ran a bunch of tests that came back negative, and she's currently on Okervvis.
No, I don't think that it's common that people impacted by MS have a high platelet count. Sometimes a high platelet count is a reflection of inflammation somewhere. But again, I don't have enough information about all the other cell lines to be able to speak intelligently.
And what are your thoughts on MRIs without the gadolinium contrast to limit exposure to heavy metals?
So gadolinium has gotten a really bad rap. And there's concerns that there's two types of concerns. One concern is that gadolinium could hurt your kidneys. And the other concern is that gadolinium might get trapped in the brain. That's called sequestration. And I believe firmly that if you have kidney dysfunction, we have to be very cautious about using gadolinium. I have found that macrocyclic gadolinium molecules, so these are cyclic like a circle, tend not to be sequestered in the brain nearly as much, if at all, compared to the old gadolinium, which were linear molecules. So linear, bad, macrocyclic, good. Many neurologists are starting to avoid gadolinium when they get scans. And where do I weigh in on this? Number one, when you're trying to diagnose someone with MS, I think gadolinium is absolutely relevant and very, very important. In fact, some of the diagnostic criteria lean on gadolinium to help confirm a diagnosis. Now, that's actually changing, and there's now new and exciting ways of also interpreting an MRI, but I still think that as part of the diagnosis process, getting a contrasted gadolinium-enhanced scan has great value. When you're surveying someone who has MS and you're getting, let's say, an annual MRI of the brain, or every couple of years you're getting a spine or what have you, it's still my preference to obtain gadolinium. So all things being equal, I would like to have it because it does teach me more information. However, if the patient has a concern, I don't argue with them and we just don't get it. And I tell the patient, we can still learn vast amounts of information with an MRI without gadolinium. We lose, I would submit to you, maybe 10, 15% of the potential value, which is still a very, very valuable test.
Karen's asking if there's any MS cognition studies testing GLP-1. If not, in your opinion, do you think there is a possibility that GLP-1 could reduce cognition and memory issues in people with MS?
So the data that I'm aware of, it just looks at the safety of GLP-1. So these are these semaglutide injections that have become very popular for weight loss. They were invented and most of the time utilized in the setting of diabetes, but they're taken by lots and lots of different people without diabetes to help them lose weight. And the party line as it relates to MS is that they're probably very safe in the setting of multiple sclerosis. I certainly do not have an issue with my MS patients taking them, all things considered. I'm not aware of a paper that looks at GLP-1 benefits to cognition. Now, you could make some correlations because there's some papers that suggest that obesity might have a negative impact on MS. And so you might hypothesize that if you could drop obesity, you might improve that. But those trials have not really adequately been done.
Thank you. Can muscle relaxants be taken as needed? Once you're on drugs for spasticity, are you generally on them for life, and doses are increased?
So here's the medical disclaimer, right? I can't give you advice and you have to talk to your doctor about what's right for you, blah, blah, blah. That's stated, in my experience, yes, you can take muscle relaxants as needed. I have some patients that only take muscle relaxants sometimes before bed when they're spastic and spasming. Other patients only take muscle relaxants before certain physical activities. Other patients have to take muscle relaxants 4 times a day or they can't function. But in my experience, you're not necessarily on them for life. When you are trying to help someone with MS live their best life, there's disease-modifying therapies, which to me are really, really important and required, if you will. Because if we don't do that, it's going to make their disease move quickly. And then there's another group of medicines called symptomatic medicines. And symptomatic medicines don't slow the disease down and they don't speed the disease up. They treat symptoms to improve quality of life. And this is an example. And so a medicine like baclofen, Xanaflex, these kind of medicines that are used to treat spasticity can be very helpful. But sometimes if the side effects are too much or the spasticity gets better, then we don't need to continue them.
Mm. Carla wants to thank you. She says she's been researching Limtrada, but doesn't have a local certified Limtrada provider or center close. Closest one is an hour away. And so she's on Rituxan because she also has RA.
Well,
So,
thank you very much, Carla. That's very nice of you. There are many of us around the country that still use Limtrada in appropriate patients. And if you feel like a road trip, come up to sunny Columbus, Ohio, and we can talk.
and Alfonso says, can you tell us your opinion on BTKs for progressive MS?
So I can. Alfonso, earlier I was talking about my excitement surrounding tolobrutinib and the successful Hercules trial in secondary progressive MS, and that is a BTK inhibitor. So that was exactly what I was talking about. In the same question, I was also talking about my excitement surrounding the Perseus trial studying tolobrutinib. Again, this is a BTK inhibitor. So fingers crossed that BTK inhibitors are going to find a home for treating progressive multiple sclerosis.
Thank you. And Abir says, hello. She's a 30-year-old woman. She's had MS since 2019. The first relapse affected her optic nerve, and since then, she's had 5 relapses, but each time she's fully recovered. She says she chose not to take any disease-modifying treatment and only treats relapses with corticosteroids. She says she recently got married, and her question is about pregnancy. What precautions should she take before trying to get pregnant? Thank you.
So MS doesn't complicate fertility at all. And MS doesn't worsen pregnancy at all. And pregnancy doesn't worsen MS at all. You and I have a very strong difference in opinion as it relates to treating your MS. And we could have an engaged conversation about how I would submit to you that you really desperately need a disease-modifying therapy. You're having very, very active disease, and that scares the bejesus out of me. But as it relates to pregnancy, there's nothing that we need to do ahead of time. I would submit that in order to be the most wonderful mom possible, we want to keep your neurological status as good as we can, and not being on a disease-modifying therapy makes that very, very challenging.
Thank you. This person is saying that they've seen your videos ranking the efficacy of each DMTs. Can you rank DMTs in terms of tolerability from clinical experience?
I can. I don't know that I could do it on the fly. But let's try nonetheless. So I think that the injectables are not terribly tolerable. Particularly the interferons are poorly tolerated, and there's data to support that. In fact, when you look at American data looking at compliance and adherence, we find that, say, 2 years into taking interferons, only about 40% of people are taking them the way they're supposed to. So I think asking someone to take a shot on a long-term basis can be very, very challenging. Some of the pills are better tolerated than others. And I would submit that the most success that I've had from a tolerability standpoint is MavenClad, and then the S1P1 receptor modulators. So this is Gilenya, Mayzent, Ponvory, and the like. The fumaric esters, so these are things like Vumerity and Tecfidera, are not terribly well tolerated. I have a lot of patients that struggle to take something twice a day, and so they skip one of the 2 times, which makes the medicine not very effective at all. And it can cause facial flushing and GI upset, and so that's been a real no-go for a lot of my patients who end up stopping that medicine. Aubagio is a mixed bag. The vast majority of my patients tolerate Aubagio swimmingly well, although it can cause rarely some GI upset, so I think that's kind of a question mark. When you get into the monoclonal antibodies, I would say that of all the monoclonal antibodies, Tyabri probably has the best tolerability, with the exception that it's sometimes considered a bit annoying to have to do something every 4 weeks or every 6 weeks. For some people with certain lifestyles, that can be rather challenging. And rarely, Tyabri can increase risk of urinary tract infections, but I would say, all things considered, it's a very, very well-tolerated medicine. I think that the B-cell depleters are very well tolerated. Some patients have infusion reactions. I see that more often with BMV and Rituxan than I do with the other monoclonal antibody B-cell depleters. And some people, the minority of people, may have this so-called crap gap where there's a sense of a wearing off, but I think they're pretty well tolerated. Limrada is poorly tolerated during the infusions, but given that you take it 5 days 1 year and 3 days the next, and then never take it again, the tolerability is outstanding once you get past that. So that's a quick off-the-cuff attempt at trying to answer your question about tolerability.
Thank you. This person was diagnosed at 59 and now they're 63. They started on Rituxan for 2 years and had a relapse, and now they're on Tyabri for the last 3 years. But their veins are getting weak, and soon they'll be going on Medicare. And what med is similar to Tyabri that they could switch to other than one that's IV and that's also approved by Medicare?
So that's a complex question. There's no medicine that's similar to natalizumab. So Tyabri is a brand of natalizumab. Teruco is another brand of natalizumab, and those are very, very similar. Those are IV infusions. And mechanistically, the way they work, there's nothing that's similar to that. I have used in this exact scenario MavenClad many, many times with great success. And so if you were in my clinic, then that's the discussion that I would have with you. We would have a discussion about maybe going on the discontinuous therapy MavenClad, where you take 5 pills the first month, 5 pills the second month, and then you're done for the year. So 10 pills the first year. And then the second year, 5 pills the first month, 5 pills the second month. And then we don't treat you ever again unless you have new disease activity. Now, in a 63-year-old, that's kind of awesome sauce because they would reach into the age for Medicare and then not be on a therapy, which is kind of lovely.
Thank you. Mary Beth is saying that she's hoping to participate in a CAR T cell trial, but was not able because she's 63 and aged out. She's on Kesimpta and afraid of her future decline. Is there any hope for her future, she says?
So absolutely, there's hope for your future. Let me start by saying thank you for your interest in participating in MS research. If there weren't brave people like you who were willing to fight back and donate their time and their bodies to try to help find solutions, we would have no therapies. So thank you very, very much. I'm sorry that the age criteria for the particular trial you were looking at had a cutoff. Is there hope for your future? Yes, there's hope for your future. There's hope for several reasons. Kesimpta is a high efficacy medicine. It has data supporting slowing disease progression, which is pretty fantastic. It has some data slowing brain volume loss, which is fantastic. And we're diligently working on hosts of other therapies that we hope that will be outstanding at filling in the gaps. So for example, earlier in this discussion, I talked about the BTK inhibitors, for example, tolebrutinib. And tolebrutinib may become a therapy which can fill in a gap of smoldering MS. And so as I share my excitement about the Hercules trial for secondary progressive MS non-relapsing and the upcoming data to be released on Perseus for PPMS, I would keep you in mind.
Thank you. Michelle says she has autonomic dysfunction. Help. She needs help. Sweating, lightheaded, near syncope, tachycardia. Then if I try to push through, she gets vomiting. Not daily, but definitely in episodes. Currently daily for about 3 weeks. And then she says, and why develop spasticity if there's no new lesions?
So autonomic dysfunction is not oftentimes associated directly with multiple sclerosis. There are peripheral autoimmune diseases that can affect the autonomic nervous system. There's a neurologic condition called POTS, postural orthostatic tachycardic syndrome, which can cause a phenomenon like that. And if you're not already, I would work very carefully with a cardiologist so that we can try to figure out what to do about your autonomic dysfunction, because that sounds horrible, and I'm sorry you're going through that. The second question, why develop spasticity with no new lesions? We could broaden and say, why develop any symptom in the absence of new lesions? And there's a reason, because the areas of damage wear out as you get older. And so sometimes you don't need a new lesion to manifest a worsening in a particular area. As your body ages and as your brain and spinal cord age, the areas where the lesions exist wear out faster.
And this guest says that their neuro isn't doing blood tests. And so they're asking, should they be doing regular blood tests since they're on
Yes,
Kesimpta? They've had
yes.
no blood work done. So yes, yes, yes.
So if you look in the package insert for Kesimpta or for any B-cell depleter, it's recommended by the FDA that you check immunoglobulins, which is a fancy way of saying antibodies. Many of us also check the absolute lymphocyte count. And I think it's a best practice to do that at least twice a year. And so I absolutely would do that. Why? Because if your immunoglobulin levels are pushed down, your IgG is pushed down below 600, or if your lymphocyte count is pushed down below 600, you're at increased risk of infection. And so I think it's a best practice to do that.
And if their doctor said no to the CD1920 test, what should they do?
So getting a CD19 count is commonly done by us neuroimmunology geeks because we're trying to make sure that the medication's working and that we've adequately depleted B cells. I get that test with the other ones that I just mentioned twice a year in my B cell depleted patients because I find it very useful for tracking. It's not an absolute necessity. And so if one of the three tests I was going to drop, that's the one that I would drop. That stated, it's your brain, it's your immune system, and it's your insurance money. And so I don't know why the doctor would be so bullheaded not to want to do that. And maybe you could ask your primary care if they would be kind enough to order it for you.
Okay, what are your thoughts on IVIG in place of DMD?
So DMD, disease modifying drug, or oftentimes we say DMT, disease modifying therapy, same thing. So they're asking, could you use IVIG? IVIG has been studied a little bit in treating MS, and I think that it works to treat MS. It's extremely expensive, and it's not FDA approved. And so it makes a logistical challenge in trying to get it approved to treat MS, but I have found it to be effective. I think that there's FDA-approved therapies that have much, much greater amounts of research supporting their use. But there are situations, and I have some patients in my clinic, where for various complex reasons, we are using IVIG to treat their multiple sclerosis.
Yeah, and your thoughts on Empira being beneficial and its side effects?
Empira, or 4-aminopyridine, or delfampridine, that's all the same medicine, because God forbid medicines only had one name. That would be way too easy. Is not a disease-modifying therapy. It doesn't slow down MS. It treats a very specific symptom, which is rather unique to MS, and that's heat sensitivity and motor fatigue. So some people impacted by MS, when they get overheated, either because they live in a hot environment and it's warm outside, or because they're involved in physical activity and they raise their core body temperature, they can short circuit. And so in the setting of getting overheated, their old neuro symptoms come back out. For example, their legs become weak, and then they have to rest or cool down before they can keep going. In this unique situation, Empira can be very, very helpful because it buttresses against motor fatigue and heat sensitivity. In my experience, and I was very involved in the clinical trials, and I use Empira quite frequently in my clinic, it only works in about half to a third of patients that try it. And we're not smart enough in neurology to figure out who's going to respond and who isn't. And so we give it to you, and I feel like it takes about 2 months to really sort out if you're going to respond or not. It's a twice-a-day medicine. It is an absolute no-no medicine if you have a history of seizures, because it can lower the seizure threshold. It also is a medicine that you have to use very carefully if you have kidney dysfunction, because it's metabolized by the kidneys, and so that can sometimes be a problem. Lastly, it's rather activating for some of my patients, and so it's a twice-a-day medicine. You need to make sure that the second dose isn't right before bed, or it can really, really interfere with sleep.
Mm. Can BTKs be used in combination therapy with peripheral anti-CD20s in the setting of PMS?
That, Alfonso, is a brilliant question, and it's an unanswered question at present. We have not studied combining protein tyrosine kinase inhibitors with other medicines, and so we don't know the answer. In the field of MS neurology, we've had some bad experiences in our previous attempts at combining medicines, either because of side effects or because they haven't worked. But your point is outstanding in that many, many fields that are farther along than ours, so rheumatology, I think is farther along, infectious disease is farther along, oncology is much farther along, have found absolute success by combining medicines. And I think that in 10 years, 15 years from now, we're going to be seeing a lot of combination therapy as a solution to trying to do a better job of treating MS.
Hmm, that is a good question. Laura's asking, are the new McDonald's criteria being used yet? And will people with a uncertain diagnosis be called back to be rechecked?
So Ian McDonald was a fantastic gentleman. He recently passed away, and he was an English neurologist who coined the McDonald criteria, which first came out in 2001. And they've been revised and revised. They were revised in 2005 and 10 and 17, and they were recently revised yet again. And I think we're calling it the 2023 or 2024 revision. And in this revision, we've really found ways of leveraging the MRI in some new exciting ways to diagnose MS much faster. And I'm very, very excited about the changes. Some of the biggest changes are identifying that the criteria for primary progressive MS and MS are really, really very, very similar. And you can kind of apply the same criteria. Another really exciting piece is that we're using a new MRI technology, looking at not a new sequence, but a new way of looking at the MRI to look for what's called the central vein sign, or something called pearls, so paramagnetic rims. And this is a way of characterizing lesions, which is very, very specific for demyelination. With these changes in mind, we can now diagnose MS much faster than we used to be able to. We'll now be able to diagnose MS on one scan with much more accuracy than what we could do in the past. It's very, very exciting. Now, these criteria are currently being written up, and so the papers are not out yet, but many of us in the field are very familiar with them. They've been presented at many congresses, and many of us, myself included, are using them in clinical practice now. Would someone who didn't meet criteria in the past be reevaluated? I would hope so.
Thank you. How does neurofilament light chain work in MS? As this person just had theirs tested and they're in their MS blood work. They've had MS for a really long time.
So when you have a neuron, so that's the cell, the nerve cell in the brain, and I will use this iPhone charger as an example of a neuron. So you have the cell body, that'll be my fist, and then you have this long sticky outy part, okay? And the long sticky outy part is called the axon, right? And inside the axon, if you were to crack it open, are a bunch of filaments. And there's heavy filaments, medium and light chain filaments. And when you crack the axon, the filaments inside dump out. And they float around the spinal fluid and they eventually make their way into the bloodstream. And when there's damage to the nervous system from any cause, neurofilament light chain goes up. So if you have, God forbid, Lou Gehrig's disease, ALS, or if you have a traumatic brain injury, or if you have a stroke, or if you have MS, you'll see neurofilament light chain go up, which means that we can't use it to diagnose MS because it could be up because of anything. But it is probably very helpful, in my opinion at least, to monitor MS. Now, earlier in the discussion, someone asked about the Octave test, that blood test that I talked a little bit about, called the disease activity, the DA Octave test. And I mentioned quickly that there's 18 different biomarkers. One of the 18 biomarkers is neurofilament light chain. And there was actually a really cool paper done by the investigators who developed this. And they looked at the Octave 18 biomarkers against neurofilament light chain by itself. And this was more predictive than this. So I do think that neurofilament light chain, whether it's by itself or whether it's part of the Octave investigation, does finally have some type of role in measuring disease activity in MS.
Thank you. What are your thoughts on using metformin for MS inflammation?
So metformin is an exciting therapy to think about in the setting of MS. It's FDA approved for diabetes.
Mhm.
And mechanistically, it sort of tricks the brain into thinking that you're in a fasting state. And there's some potential hope that that might help with MS in a couple different ways, including with remyelination. Am I running out and putting all my patients on metformin? No, I'm not. Stay tuned, though, because it's one of the hopeful drugs that might help with remyelination.
And what can you tell about regeneration therapies? PIPE 307?
So Pipe 307 is gotten a lot of press recently. I would love to hire the marketing people that were involved with promoting that because, boy, everyone talks about it. And there's good reason because it's very, very exciting. Those trials are ongoing. We don't have data yet to share. Really, when we say regeneration, I think what Alfonso means is remyelination, and the ability to put myelin back on the nerve. If I was to go back to using this, let's say this is a nerve and it's got a plastic coating on it, MS strips off the plastic coating. We want to put that back on. And so there are several therapies that are under investigation, including Pipe 307, hoping that we can remyelinate. We're not there yet.
Thank you. So Sydney says that she has both brain and spine lesions. So she wants to make sure that she's taking the best DMT. She said that she's heard that pill DMTs only help brain lesions, where infusions help both brain and spine lesions. Is this true?
It's not true based on like the clinical trials, like no spine lesions were helped with pills. That stated, I do think that, as it turns out, the infused monoclonal antibodies tend to be more effective and more effective maybe in severe disease than the pills do. And so when I see someone who has brain and spine lesions, having spine lesions is suggestive of a more aggressive disease course. I will tend to gravitate towards the monoclonal antibodies because I'm trying to pick up the most efficacious thing I can. But as phrased, no, I don't think that there's data saying monoclonal spine, pills, no spine.
Hmm, thank you. Um, are some people on DMTs for life if they've been diagnosed with active secondary progressive?
Yes, I think that you should take a DMT up until death. After death, I don't think that they work very well, but pre-death, I absolutely believe in treating people.
What are your thoughts on taking Kesimpta every other month? Or their copay assistance only covers 18,000 a year, so they are unable to afford it after that runs out, which is only 4 to 5 doses.
So I think that's a terrible idea from a medical standpoint. It's a terrible idea because Kesimpta doesn't stick around in the body that long. And so I would be very concerned that if you were taking Kesimpta infrequently, that you would have periods where your B cells returned and then could attack you. And so I don't think that's probably a very viable option. I am very sensitive to your comment that the copay assistance doesn't cover things, and that might necessitate some other creative mechanisms to get that covered and switching to a different disease modifying therapy.
Thank you. And do the number of O bands mean anything in regards to disease severity? Because they had 13 when they were diagnosed.
Probably not. They probably don't. There's maybe a little bit of literature suggesting possibly, but generally speaking, I don't see more bands equals more bad. I will say that the presence of oligoclonal bands is an independent risk factor for more aggressive disease compared to not having bands, which is not that impressive of a statement considering that 90% of people with MS have unpaired bands.
Thank you. And this will be our last question for tonight. Is it uncommon, Paul is asking, is it uncommon for someone 73 years old to have a seizure? Only had one before, and that was 15 to 20 years ago. Thank you.
So, howdy, Paula. People impacted by MS are arguably 6 times more likely to have seizures compared to the general population. I don't know that there's something specific about being 73 which would increase that risk. But if you've had a history of seizures, you remain at risk of having seizures. The good news is it's relatively easy to treat most seizures, and we can typically knock it out with a pill. And so I'm very hopeful that you can get on a therapy and make sure that never happens ever again.
Thank you. And that does bring us to the end of our time. If you've missed any part of this conference, it has been recorded and it's going to be available through the MS Focus Facebook and YouTube channels. Just reply to your registration email for information on how to access the recordings or sign up for our newsletter, which is where you'll learn about all the upcoming events. Our next teleconference is going to be Wednesday, May 7th at 3:00 p.m. Eastern. And that's when Nurse Sherry Binns, who also lives with MS herself, will be answering your symptom management questions during another 60-minute Q&A. As you leave the conference today, a survey will appear on your screen. We ask that you please take just a moment to give us your feedback on this program and your suggestions for future topics. That way we can figure out what's most important to you and we can give it to you. Our sincere thanks to all of our attendees for your participation, and especially to Dr. Boster, who once again shares his knowledge and has one-of-a-kind personality. And we're so happy to have you every other month. We love it.
It's a pleasure and an honor. Thank you for having me.
Thank you. And for all of those of you who were kind enough to put more questions in and weren't able to get the answers, he is going to be back in not next month, but the month after. And if you would like to do it on the month that he is not here, if you can hold your question till Dr. Thrower, every month we have somebody answering questions, whether it's Dr. Boster or Dr. Thrower. They're both capable of answering them. So you want to wait for Dr. Boster, you got another month to 2 months to go. And if not, come next month for him. So anyway, have a wonderful evening, everybody. Again, thank you so much, Dr. Boster. We love you, and we'll see you all soon.